Welcome to the Deep Dive. Today we're tackling a really significant public health issue in maternal fetal health, one that often, well, flies under the radar despite being quite common. We're talking about cytomegalovirus, or CMV, infection during pregnancy.
That's right. It's often called a silent threat, but its potential impact on newborns can be profound.
Absolutely. So in this deep dive, our goal is to give you, whether you're deep in fetal medicine studies, a physician monitoring pregnancies, or just someone keen on staying updated, a clear, solid understanding of CUZ. We'll unpack the risks of congenital CMV, look at the latest diagnostic tools, and explore how management and prevention strategies are evolving.
And we'll definitely need to talk about the recent developments in France, specifically that important June 2025 opinion from the French High Authority for Health, the HAS.
Exactly. We're pulling together the latest research, expert consensus, and those very recent policy shifts to paint the current picture for you. Okay, let's start at the beginning. What exactly is CMV, and why is it such a major concern during pregnancy, especially given how common it seems to be?
Right, so CMV, or cytomegalovirus, is a DNA virus. It's part of the herpes virus family. And like other herpes viruses, once you're infected, it stays with you for life, setting up latency, but with the possibility of reactivating periodically.
Okay, so it sticks around. Why the focus on pregnancy then?
Well, the big concern is congenital CMV, or CCMV.
Mhm.
This happens when the virus is transmitted from mother to fetus during pregnancy. And CCMV is actually the most frequent congenital infection worldwide. We're talking about a prevalence of around 0.64% of all births.
Wow, 0.64%. That sounds quite high on a global scale.
It is. And critically, it's a leading non-genetic cause of sensorineural hearing loss, SNHL, and also brain disease in children. The overall risk is substantial. Something like 17 to 20% of infants infected with CCMV will face serious long-term effects.
Given those serious potential outcomes, how common is CMV infection among pregnant women themselves? Is it something most people encounter?
It's incredibly common. If you look at seroprevalence, the percentage of people with antibodies showing past infection in pregnant women in Europe, it typically ranges from 50% up to 85%.
50 to 85%. That's a huge range.
It is, and it varies by region. In the U.S., it's estimated around 60%. Recent French data from 2010 suggested about 45.6% for women aged 15-49. So yes, a large portion of the adult population has encountered CMV, which really highlights the challenge.
That widespread presence is definitely striking. But does any maternal CMV infection carry the same risk for the fetus? Or are there specific situations we worry about more?
That's a really critical point. We mainly distinguish between two types, primary maternal infection, or MPI,
Good for MPI.
and non-primary maternal infection, NMPI. MPI is when a woman gets infected with CMV for the very first time during her pregnancy. The incidence of MPI is estimated at about 1 to 2% of pregnancies.
So relatively uncommon for a first-time infection during pregnancy itself.
Right, but here's the key. The risk of transmitting the virus to the fetus vertical transmission is around 32% with MPI. And interestingly, that transmission risk can actually increase as the pregnancy progresses, potentially reaching up to 66% if the primary infection happens in the third trimester.
66%. Wow. Okay, so what about the other type? NMPI.
NMPI happens in women who already have CMV immunity from a previous infection. It could be a reactivation of their latent virus or maybe even a reinfection with a different CMV strain. Here, the vertical transmission risk is much, much lower, likely less than 3.5%.
Less than 3.5% versus 32% or more. That's a huge difference.
It really is. And it's worth noting that in Europe, about half of all congenital CMV cases seem to follow a primary maternal infection.
So it's those new primary infections during pregnancy that pose the highest transmission risk. You mentioned transmission risk increases later in pregnancy, but what about the risk of harm to the baby if transmission occurs? Does timing matter there too?
It absolutely does. And this is perhaps one of the most vital pieces of information we have now. The severe long-term sequelae, we're concerned about the hearing loss. The neurological issues seem to be exclusively linked to infections following a maternal primary infection that occurs in the first trimester.
Exclusively first trimester.
Yes. The estimated risk for serious long-term problems in those specific cases is high, somewhere between 51 and 57%. But crucially, based on current data, no long-term sequelae have been reported in children infected after a primary maternal infection acquired later in the second or third trimester.
That's a game changer. So even if transmission happens later, the risk of severe long-term damage drops off dramatically.
Precisely. It really focuses our concern on that early window of gestation.
Okay, so let's focus on the critical first trimester scenario. If a fetus gets infected early on following a primary maternal infection, What are the potential long-term consequences we're talking about?
For those infants infected early, the outcomes can be serious. We see potential for significant neurological issues like mental retardation, cerebral palsy, and, as mentioned, sensorineural hearing loss, SNHL.
And the hearing loss isn't always straightforward, is it?
No, it's not. SNHL related to CCMV can be late onset, meaning it appears after the newborn period. It can also be progressive, getting worse over time, or it might fluctuate. This affects about 20 to 30% of the SNHL cases in these children. And beyond hearing, there's also vestibular dysfunction problems with balance, which affects around 17% of kids with CCMV, and it can really impact their early motor development.
It sounds like a wide range of potential issues. You also mentioned symptomatic versus asymptomatic newborns earlier.
Right. A key point is that the vast majority, maybe 90%, of newborns with CCMV appear asymptomatic at birth. They look healthy.
Which sounds reassuring, but
But about 13.5% of those seemingly asymptomatic babies can still go on to develop sequelae later, like hearing loss.
okay, so asymptomatic at birth doesn't mean completely out of the woods.
Exactly. And for the 10% or so who are symptomatic at birth, showing signs like jaundice, small head size, or enlarged liver and spleen, the risk of long-term neurodevelopmental impairment is much higher, ranging from 30% up to 66%.
It definitely sounds like a stealthy virus in many cases. So, how do clinicians try to predict the outcome for an infected fetus, especially given that risk of late onset issues?
Prognosis is challenging, but fetal imaging is incredibly helpful. Ultrasound and increasingly fetal MRI can give us important clues. If we see certain findings like a thickened placenta, an enlarged liver and spleen, hepatosplenomegaly, enlarged brain ventricles, ventriculomegaly, or tiny calcium deposits in the brain, intracranial calcifications, these are often associated with symptomatic disease at birth and a poorer long-term prognosis.
So, those imaging findings help guide counseling and preparation.
Yes, they provide crucial prognostic information.
Okay, this brings us to the practical side. With these complexities, how do we actually detect the infection, both in the mother and then, if necessary, in the fetus? What's that diagnostic process like?
It really starts with the mother. Establishing her CMV serological status is the first step. Usually this involves testing her blood for IgG and IgM antibodies.
Standard antibody tests.
Right. But there's a big caveat with IgM. A positive IgM result isn't, on its own, specific for a recent primary infection.
Why not?
Well, IgM antibodies can sometimes persist for many months after an infection. Or sometimes a positive IgM can be due to cross-reactivity with other viruses, or even part of a non-primary infection like reactivation. It can definitely muddy the waters.
Okay, so if IgM is ambiguous for timing, how do you pinpoint when a primary infection might have occurred, especially given that crucial first trimester risk window?
This is where the IgG avidity test becomes essential. Avidity measures how strongly the IgG antibodies bind to the virus. Low or intermediate IgG avidity combined with positive IgG and IgM strongly suggests a recent primary infection, usually within the last 1 to 3 months.
So the avidity test helps date the infection.
Exactly. It's key for accurate risk assessment. And if we get weekly positive IgG results, we typically repeat the test or send it to a reference lab for confirmation.
Is this kind of serological testing, including avidity, done routinely for all pregnant women in Europe?
No, it's not universal practice everywhere. Routine screening policies vary between countries. The decision often comes down to local factors like the prevalence of CMV and cost-effectiveness analyses. Although it's interesting, a recent French cost-effectiveness study suggested that universal screening, if paired with valacyclovir treatment for prevention, could actually be cost-effective. That finding is definitely shaking things up.
We'll definitely come back to that French situation. But first, if maternal testing indicates a recent primary infection, how do you confirm if the fetus has actually been infected?
The gold standard for diagnosing fetal CMV infection is CMV PCR testing on amniotic fluid, obtained via amniocentesis.
Okay, PCR on the amniotic fluid. Is there a specific time to do that?
Yes, timing is critical for accuracy. The amniocentesis should be performed at or after 17 weeks of gestation. And, importantly, at least 8 weeks must have passed since the suspected maternal primary infection occurred.
Why those specific timings?
Waiting until 17 weeks ensures there's enough fetal urine, which is the main source of virus in the amniotic fluid, and waiting 8 weeks after maternal infection allows enough time for the virus to potentially cross the placenta and replicate to detectable levels in the fetus and fluid. Under those conditions, the PCR test is highly reliable, Specificity is nearly 100%, and sensitivity is excellent, around 87% to 95%.
So if the PCR comes back negative under those conditions, that's very reassuring.
Extremely reassuring. A negative CMV PCR on amniotic fluid, done at the right time, essentially rules out fetal infection and the associated risk of long-term sequelae.
And if the fetal PCR is positive, what happens then?
If fetal infection is confirmed, that's when we strongly recommend detailed fetal imaging, both ultrasound and potentially MRI, usually in the third trimester. As we discussed, this helps assess the potential severity by looking for any CMV-related abnormalities in the fetus, giving crucial prognostic information.
Okay, so we've covered the risks and the diagnostic path. Now the crucial question, what can we actually do about it? What are the latest developments in prevention and treatment?
This is where things have become much more hopeful recently. A major advance is the use of valacyclovir during pregnancy to prevent vertical transmission.
Valacyclovir, that's an antiviral medication.
Yes, it's commonly used for herpes simplex. Studies have shown that giving oral valacyclovir at a fairly high dose of 8 grams per day can reduce the rate of CMV transmission from mother to fetus by about 70%.
70% reduction, that's huge. When is it used?
It's shown benefit when given following a primary maternal infection acquired around conception or during the first trimester. And the evidence suggests that starting the treatment as early as possible after the maternal infection is key for effectiveness.
With any medication in pregnancy, safety is always the top concern. What do we know about the safety of high-dose valacyclovir?
The safety profile has been studied quite extensively now. Some women, maybe around 21%, experience mild side effects like nausea or headache. There were reports of acute renal failure in a small percentage, around 2 to 4% of cases, but this resolved when the treatment was stopped.
And crucially, any risk to the baby.
Importantly, looking at data from nearly 1,000 pregnancies between 2007 and 2023 where high-dose valacyclovir was used, there's been no signal suggesting it causes birth defects, no teratogenicity.
That's very reassuring. Are there other preventative treatments? What about hyperimmune globulin?
Hyperimmune globulin, or HIG, was studied, but unfortunately randomized controlled trials haven't shown significant efficacy in preventing vertical transmission. So valacyclovir is really the main focus for prevention right now.
Okay, so valacyclovir for prevention during pregnancy. What about treatment for the baby after birth if they are infected?
Yes, for newborns diagnosed with congenital CMV who have symptoms affecting the central nervous system or even isolated hearing loss, treatment with a different antiviral, valganciclovir, is recommended.
Valganciclovir, different from valacyclovir.
Correct. Valganciclovir has higher direct anti-CMV activity, but also comes with a more significant toxicity profile. We worry about things like myelosuppression affecting blood cell counts and potential kidney or testicular toxicity.
So it's reserved for more severe cases.
Exactly. It's typically reserved for symptomatic newborns. Ideally, treatment should start as soon as possible, definitely before 1 month of age, although starting between 1 and 3 months might still offer some benefit, particularly for hearing outcomes.
And for children identified as high risk, what kind of follow-up is needed long-term?
Long-term specialized follow-up is absolutely vital. For children with confirmed infection after a first trimester maternal infection, or those with symptoms at birth, hearing loss, or concerning findings on brain imaging, they really need close monitoring up to at least age 6. This includes checking for neurodevelopmental progress, behavior, learning issues, and especially late onset or progressive hearing loss.
What about vision?
Ophthalmological follow-up is generally only recommended if the infant has retinitis inflammation at the back of the eye detected at birth.
Beyond these medical interventions, what about basic prevention? Can simple measures help?
Definitely. Improving education for both women of childbearing age and healthcare professionals about CMV is key. Simple hygiene measures like frequent hand washing, especially after contact with diapers or young children's saliva, have been shown to be highly acceptable and can significantly reduce the risk of acquiring CMV.
Good hygiene, simple but effective.
And looking further ahead, there's also active research into CMV vaccines, which could offer primary prevention in the future. Several candidates are in development.
Vaccine development would be a huge step. Now let's pivot to that major policy shift you mentioned, particularly in France. You said systematic screening wasn't recommended for years. What changed?
Right. For a long time, the official stance in France from the HAS as recently as 2023 was against systematic CMV screening for all pregnant women.
And why was that?
The main reasons cited were the lack of a proven, effective treatment to prevent fetal harm and concerns about the overall benefit-risk balance of universal screening, things like anxiety from results, potential for unnecessary interventions. This was similar to the position in many other countries.
So what's happened now? You mentioned a June 2025 opinion.
Exactly. In June 2025, the HACIF released a new opinion, and it represents a major shift. Based on new analyses, including a meta-analysis looking at velociclover, they now consider the hypothesis that velociclover is effective in reducing vertical transmission to be founded.
Founded. That sounds like cautious but positive language.
It is. It signals a significant change in their assessment of the evidence for preventative treatment.
Was it just the velociclover data, or were other factors involved, like that cost-effectiveness study you mentioned?
That study was definitely influential. The French cost-effectiveness analysis showed that universal screening, when linked with offering velociclover for primary first trimester infections, could be cost-effective compared to the current approach. The model suggested it could massively increase the detection rate of fetal infections from maybe 15% currently up to potentially 94%.
94% detection.
And importantly, it could potentially reduce the number of severe congenital CMV cases by about 58%. That's a huge potential public health impact.
Were the ethical concerns addressed? The anxiety? The risk of invasive procedures?
They were definitely considered. The potential downsides, false positives, anxiety, the small risk associated with amniocentesis if pursued, are still acknowledged as part of the balance. However, the ACE also noted something interesting. In areas or studies where screening has been implemented more widely, there hasn't been an observed increase in medical terminations of pregnancy for CMV.
That's an important observation regarding how the information is used.
It suggests that increased detection doesn't automatically lead to more terminations, but rather allows for more informed counseling and preparation, including potential treatment options.
So what was the final decision from the HAS in June 2025?
The core decision is quite groundbreaking for France. The HAS is now recommending a 3-year experimentation period for systematic CMV screening for all pregnant women nationwide.
Experimentation period, so not a permanent policy change yet.
Correct. It's a cautious, evidence-gathering approach. During these 3 years, specific protocols will be followed. This includes using defined algorithms for interpreting the serology results, developed by the National Reference Center for Herpes Viruses, and following provisional clinical guidelines for managing women who screen positive.
And what happens after 3 years?
The HISS has committed to a formal reevaluation. They need more data from this real-world implementation. They'll be looking at CMV epidemiological trends, how well the screening tests perform in practice, and critically, more long-term data on whether velociclovir actually reduces the sequelae, the long-term disabilities, not just transmission.
So proof of concept for reducing bad outcomes, not just infection rates.
Exactly. They also want to assess the quality of information given to women and the training level of healthcare professionals involved. It's about ensuring the whole system works effectively and ethically.
This has been an absolutely fascinating deep dive. We've gone from understanding the basics of CMV as this common, often silent virus, to grasping the critical importance of that first trimester primary infection risk.
Through the nuances of diagnosis with serology, avidity, and amniotic fluid PCR.
And on to the really exciting developments in management, especially velociclover for prevention and valganciclover for treating affected newborns.
And culminating in this landmark decision in France to trial systematic screening.
It really highlights how science, clinical practice, and health policy are constantly interacting and evolving. So the final thought for you, our listeners, what does all this mean going forward? How might this evolving understanding, and particularly this French experiment, change things? It could profoundly impact families affected by CMV, of course. But might it also set a precedent for tackling other complex congenital infections globally? What lessons can be learned from this careful strategy that tries to balance cutting-edge science, ethical considerations, and practical, real-world implementation?
It's definitely a space to watch. The journey to fully mitigate the impact of CMV is ongoing, and how we navigate screening and prevention will continue to be a critical conversation in maternal fetal health.